Last time we were talking about the heart. We were talking about the four chambers. We were talking about the great vessels. And I would like to remember specifically some structures such as the coronary vessels because they are very important. They are the vessels for nutrition and oxygen for the heart. Then we have the two first blood vessels uh, to be branched on the aorta are the coronary vessels. Then we have the left coronary artery and we have the right coronary artery. Then we have here the branches. As you can see here, you have the branches. From the left coronary artery, we have the circumflex branch and the anterior interventricular artery. If you can see here, this is the anterior interventricular sulcus, and this is the anterior interventricular artery. And the other artery is the right coronary artery, and we have the posterior interventricular artery and the right marginal branch. If you can see the posterior view of the heart, you're going to see this sulcus is going to be the posterior interventricular artery, and we have here these branches. Regarding the veins, we need to get back that blood after using the oxygen, after using the nutrients. We need that blood back to the heart, and we're using the cardiac veins, and these veins is draining in these huge blood vessels. This one is called the coronary sinus, and finally it's going to arrive to the right atrium. Remember, when we have oxygenated blood, it's going to be on the left side. Aorta is departing from the left ventricle, and the coronary sinus is going to be draining on the right side because the right side is the side for the deoxygenated blood. Then remember, for the right atrium, we're receiving there the superior vena cava, the inferior vena cava, such as you can see here, superior vena cava, inferior vena cava, and the coronary sinus. These three blood vessels are draining blood into the right atrium. The second thing I would like to remember, guys, about the last session is the structure of the about the structure of the cardiac muscle. If you remember, this muscle has a cell which is a branch shape like a tree, and you have striations and you have divisions between these two cells. These divisions are called intercalated disc. Guys, these structures, the intercalated disc, they allow to contract the whole heart at the same time because the contraction should be efficient. Then the whole heart, it's contracting at the same time. I'm going to stop for a second here. I would like to know if you're able to hear my voice. Jasmine and Osvaldo, are you able to hear my voice? Are you able to see my screen? Because I'm trying to record this session. Thank you, guys. Thank you. Then I'm going to share again my PowerPoint with you. Then the third thing I'm going to show you in this video, guys, is the conduction system. Remember, we have electricity and we need to transmit the whole electricity for the whole heart. The action potential, if you remember AP1, the action potential is going to be there. And then the electricity should be spread to all of the heart in order to get the contraction. Then, if you remember, we watched a video about this. I'm going to look for the video, and then we're going to stop again on the video because it's really, really important you remember this part. Give me a second. I'm going to share with you my video. This is going to be right here. And we're looking for the video about the cardiac conductive system. By the way, guys, you already have these videos. You already have these videos in your Remind app. You have the links. I'm going to show you this. Open the link. and let me know if you're able to hear the
The
voice for
cardiac
the video.
conduction system consists of the following components: the sinoatrial node, or SA node.
Okay, are you able to hear the voice for the video? Nice, very nice. Okay, then I'm gonna share with you again, and this time it's gonna be the video.
Located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The Atrioventricular Node, or AV node, located on the other side of the right atrium, near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of
Then, if you remember the video last time we were discussing the video, you remember we have, guys, this is the SA node or sinoatrial node. And then we need to spread the electricity, the action potential through the whole heart. Then we're getting first the two atrium. And then the second station is going to be the AV node or atrioventricular node. Then here is going to be a delay to reach the contraction or the systole, if you remember the word systole, for the atria. Then we transmit that action potential to this branch, and this branch is the AB bundle or bundle of His. Then we have two branches, left side to the left side of the heart and right side to the right side of the heart. And finally, to distribute the whole action potential in our heart, we have these fibers. These fibers are called Purkinje fibers. Guys, these action potential, they have the representation for this action potential is going to be the ECG or electrocardiogram. And if you remember, we're going to look here for the shape for the waves. If you remember, the first wave is going to be the P wave. Actually, let me show you guys. I'm going to stop here. I'm going to try to edit this with you. Then you have here, this is the P wave. And the P wave, it's going to be for atrial depolarization. It's going to be the atrial depolarization. After that, after the atrial depolarization, we have the space for the systole of the atrium. Then you have the second complex is going to be the QRS complex, as you can see here. And this one is the depolarization of the ventricles. After that, you have the space, which is called ST, for the contraction or systole of the ventricles. And finally, you have a third wave, which is the T wave. And this one is going to be for the ventricular repolarization. And again, you have then ventricular depolarization is going to be QRS. Ventricular repolarization is going to be the T wave. Now, the atrial repolarization, we cannot see that in the ECG. Why? Because it's right behind of the QRS complex. The QRS complex is masking the atrial repolarization. Then we cannot see that. And we're going to see again our video, guys. I'm gonna go over the video again. See, remember, this is the ECG or repolarization
of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial Re-Polarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Then, guys, this is the actual explanation of the ventricular and atrial depolarization and repolarization. This is the electrical activity for your heart. And I'm going to stop sharing here for a second. And I would like to know, guys, do you have any questions so far? Do you have any questions so far, guys? Okay, I'm going to stop a second. The second video I'm going to show you guys is about the calculation of the heart rate. We're going to use the calculation again for the heart rate, and I'm going to explain you two methods. We're going to see a short video, and then I have here a whiteboard, and I'm going to explain to you again the calculation of the heart rate. Again, we're going to have a short video here. We have the last video, and this is going to be, pay attention, we're going to use only two methods, the big squared methods and the small squared methods. One of them is faster, the other one is more accurate. Pay attention to this video, guys.
Welcome to Proven Doctor with another episode of ECG Basics. In this video, we will speak about heart rate calculation by ECG. There are a few methods of heart rate calculation. The square counting method is very easy, and it doesn't need any difficult calculation. When ECG is recorded with a speed of 25 millimeters per second, you should use the sequence 300, 150, 100, 75, 60, 50, 43, 38, and 33. Counting off every large square is performed from one QRS complex to the following one. The first large square, or 5 small squares, denotes 300 beats per minute. The next one denotes 150 beats per minute, etc. If ECG speed is 50 millimeters per second, you can use this sequence, but in this case, you should count every 2 large squares. The second method needs a calculator. You should count small squares between two sequential QRS complexes. If ECG speed is 25 millimeters per second, divide 1,500 by the number of small squares. Also, you can calculate the number of large squares. Then, divide 300 by the number of large squares. If ECG speed is 50 millimeters per second, divide 3,000 by the number of small squares, or divide 600 by the number of large squares. The marker method is the best for calculating the heart rate in patients with irregular rhythms. You should count the number of QRS complexes during 6 seconds and multiply it by 10. On ECG, recorded with a speed of 25 millimeters per second, 30 large squares correspond to 6 seconds. If ECG speed is 50 millimeters per second, 60 large squares correspond to 6 seconds. Another method of determination of the heart rate is based on the calculation of the RR intervals. At first, you should calculate the RR intervals. Count the number of small squares and multiply it by 0.04 if ECG speed is 25 millimeters per second, or multiply it by 0.02 if ECG speed is 50 millimeters per second. Then, divide 60 by RR interval measured in seconds. Thank you for watching.
Okay, guys, I understand this can be a little bit overwhelming because it's math, but I'm going to try to explain to you this as simple as I can. We're going to get only two methods. The first one is counting the big squares, and the last one is counting the small squares. And you can see here, one of them is going to be faster. You only have to count the number of big squares between complexes. If you have an R, which is a peak, and you count the number of big squares, and why is 300 that number? Because remember, the paper is moving 25 millimeters per second. Then you're going to have, in 1 second, you're going to have 300 small squares. That's the reason it's 300. Then when you divide 300 by 1, your heart rate is going to be 300. When you divide 300 by 2, your heart rate is going to be 150. When you divide 300 by 3, your heart rate is going to be 100. When you divide 300 by 4, you're going to have 75 per minute. Then these, if you have 3, if you have 4, or if you have 5, is a normal heart rate. Remember, the normal heart rate is 60 to 100. If you have less than 3, you're going to have a patient with tachycardia. More than 100 is going to be tachycardia. And if you have a patient with 6, 7, or more big squares between R and R, you're going to have bradycardia. Then remember, guys, this method is really fast, but it's not accurate. Instead of that, maybe you can count the small squares. Then imagine instead of 3 big squares, you have 3 big squares and a little bit more. Maybe 3 big squares and 3 small squares. You already know a big square is 5 small squares. Then you multiply 3 by 5, it's going to be 15. And you add the other 3, you're going to have 18 small squares. Then you have to multiply these by 0.04. Why? Because because remember, your paper is moving 25 millimeters per second. And this only 1 millimeter is going to be 0.04 seconds. That's the reason. Then 18 multiplied by 0.04 is going to be 0.72. Then in 1 minute, 60 seconds divided by 0.72, your heart rate is going to be 83. This one, it's more accurate. I understand it's a little bit more confusing because of the math, but it is what it is, guys. If you remember your high school, you were thinking, oh, I'm not taking engineering, or I'm not taking any math course because I hate it. Or maybe you hate chemistry, but nursing and anatomy and physiology is a lot of math and chemistry. Guys, I'm going to share again with you my screen. This time we're going to talk about the PowerPoint. Let me know if you're able to see the screen. Perfect. Then remember, guys, for the ECG, the first part is going to be, as well as going to be useful for the cardiac cycle. The first part is going to be the depolarization of the atrium. Then it's going to be the beginning of the ECG. Then when you have depolarization of both atria, you're going to have the P wave. Remember, this is the P wave. If you remember, P wave is going to be the depolarization at the beginning, because we have the SA nodes, the natural pacemaker of the heart. This is P wave. P wave is this one. Then you have this space called PQ segment. PQ segment. After the wave, we have the PQ segment. And this segment is the moment when the atria can squeeze, can contract. The systole for these two guys, the atria, is the segment PQ. Then after that, you have the QRS complex. And this is the depolarization of the ventricle. Remember, the Q is going to be the depolarization only for the septum. The R is going to be the depolarization of the apex and this wall. And the S is going to be the depolarization of the rest of the ventricles. Then the complex QRS is the depolarization for ventricles. Then you have another segment, another pause. And this electrical pause is going to be for the contraction of the ventricles. It's going to be for the systole of the ventricles. Then the segment ST is for the contraction of the ventricles. And finally, you have the T wave. And the T wave is going to be the recovering of the ventricle. It's going to be the repolarization of the ventricles. And after that, we're going to have the complete relaxation of the heart. Complete relaxation of the heart. Each of these phases, guys, is corresponding with the cardiac cycle. And now we're going to watch again the video for the cardiac cycle. Guys, remember this video can be a little bit overwhelming, but we're going to stop step by step on the cardiac cycle. Let me show you guys. Pay attention to the video. I'm going to stop here sharing because I would like to know if you have any questions so far. Do you have any questions so far, guys? Let me know if you have any questions so far. Okay. Then we're going to watch our video now.
The cardiac cycle refers to the sequence of events that occur and repeat with every heartbeat. It can be divided into two major phases, systole and diastole, each of which subdivides into several smaller phases. Systole and diastole, when not specified otherwise, refer to ventricular contraction and relaxation, respectively. Reminders: blood flows from higher to lower pressure. Contraction increases the pressure within a chamber, while relaxation lowers the pressure. AV valves open when atrial pressures are higher than ventricular pressures and close when the pressure gradient is reversed. Similarly, semilunar valves open when ventricular pressures are higher than aortic pulmonary pressures and close when the reverse is true. The cycle is initiated with the firing of the SA node that stimulates the atria to depolarize. This is represented by the P wave on the ECG. Atrial contraction starts shortly after the P wave begins and causes the pressure within the atria to increase, forcing blood into the ventricles. Atrial contraction, however, only accounts for a fraction of ventricular filling because at this point, the ventricles are already almost full due to passive blood flow down the ventricles through the open AV valves. As atrial contraction completes, atrial pressure begins to reverse across the valves, closing the valves, the first heart S1, and marks the beginning of systole.
Okay, guys, I'm going to stop sharing with you my screen for a second. And I would like, actually, I'm going to share the same thing, but I would like to explain step by step these phases. I'm going to use my whiteboard here in order to let you know later the names and the features of every single stage. The first stage is going to be the depolarization, as you can read in your screen. The depolarization for atria. Doesn't matter if you cannot read yet, because we're going to read this at the end. Then the depolarization for the atria is going to be the contraction, the P wave at the same time of the atria. We're ejecting blood from the atria to the ventricles. And by the way, remember, we have both sides doing the same thing at the same time. Then the right atrium is impulsing, expelling blood from the atrium to the ventricle, and the left side is going to be the same. And the moment when you have a lot of pressure in your atria, you're going to open your valves, the AV valves. Remember, on the right side is going to be the tricuspid. On the left one is going to be the bicuspid or mitral, in order to eject that blood into the ventricles. When you have now low pressure in your atria, then these two valves, they're going to close, because remember, the function of the valves, it's avoiding the backflow, and you know the blood should be only in one way, in one direction, from the atria to the ventricle. Then at the end of this systole of the contraction of the atria, we're going to have closing the valves, and this closing of the valves is the S1. If you remember, the sound of the contraction of the heart is lup-dup, lup-dup, lup-dup. The first lup is going to be because of the closing of the AV valves. Let's watch again our video, guys. Pay attention.
At this point, ventricular depolarization, represented by the QRS complex, is halfway through, and the ventricles start to contract, rapidly building up pressures inside the ventricles. For a moment, however, the semilunar valves remain closed, and the ventricles contract within a closed space. This phase is referred to as isovolumetric contraction because no blood is ejected and ventricular volume is unchanged.
Okay, guys. Then we have a second phase called isovolumetric contraction of the ventricles. This second stage is going to be because we have closed valves, 4 of them. We have AV valves are closed, we have semilunar are closed, and we have the action potential in your ventricles. Then the ventricles start to contract because you have blood inside. The pressure inside the ventricles is increasing, and ultimately they're going to open these 2 valves, the semilunar valves, at the beginning of the third stage. Pay attention.
Ventricular ejection starts when ventricular pressures exceed the pressures within the aorta and pulmonary artery. The aortic and pulmonic valves open and blood is ejected out of the ventricles. This is the rapid ejection phase. As ventricular repolarization, reflected by the T wave, begins, ventricular pressure starts to fall and the force of ejection.
Then we have a third, which is a rapid ejection. This rapid ejection, guys, remember, you have increasing the pressure in your ventricles. Then you're going to open the semilunar valves, and you have AV valves closed. By the way, guys, these things, these situations about the opening valves and closing valves, they're going to be in your exam. Then you need to focus in this information. You need to focus in this video particularly, because between the conduction and this video, maybe you have half of the evaluation for the heart physiology. Then after that, you reduce the pressure, and eventually, when you reduce the ejection, which is the next phase, the reduce ejection of the blood out of the heart, then you're gonna drop the pressure inside the ventricles, and eventually during this phase you're gonna close the semilunar valves as well. Pay attention.
Is reduced. When ventricular pressures drop below aortic and pulmonary pressures, the semilunar valves close, marking the end of systole and beginning of diastole. Closure of semilunar valves produces the second heart sound, S2. The first part of diastole is, again, isovolumetric, as the ventricles relax with all valves closed. Ventricular pressure drops rapidly, but their volumes remain unchanged.
Because we have now the ventricles with all the valves closed, is called isovolumetric again, because we have the same volume inside the ventricles, but this time we have almost no blood. Actually, this phase is called isovolumetric relaxation. And again, we don't have a lot of blood inside of ventricles because the pressure is really low. Finally, you're gonna have more blood when we're resting, when we are in diastole for the heart. Our atrium are receiving blood on the right side from the vena cava and coronary sinus, and on the left side we're receiving blood from the pulmonary veins, both at the same time. Then we're going to be filling again later our ventricles. Pay attention to the end of the video, guys.
The atria are being filled with blood and atrial pressures rise slowly. Ventricular filling starts when ventricular pressures drop below atrial pressures, causing the AV valve to open, allowing blood to flow down the ventricles passively. The atria contract to finish the filling phase, and the cycle repeats itself.
Then the last phase is going to be the filling of the ventricle, and this filling is going to be passive, without contraction. And this filling is about the 60 to 70% of the volume of the ventricles. And we're going to end with the, again, with the cycle, with the depolarization of the atria. Guys, I know this can be overwhelming. If you watch this video several times, it's going to be easier for you. But you need to understand this sequence. You need to understand the sequence of the flow of the blood inside the heart. You need to understand the difference between pulmonary circulation and systemic circulation, because this is the base for cardiovascular physiology. I'm going to stop sharing for a second, guys, my screen with you. I'm going to look for another video, which is the last video for today. It's going to be our determinants of the cardiac output. And we have a new concept here. We have a new concept, which is the cardiac output. And I would like to show you what is the cardiac output, which is a variable very important for your understanding of the cardiovascular physiology. Then I'm going to share with you this video, guys. This is my video about the cardiac output. You need to understand the cardiac output is the amount of blood ejected by every single ventricle in 1 minute. And again, sorry about that. It's a little bit math. Here, you're going to see some math here, but we need to see this. The cardiac output has 4 factors, and these 4 factors, they're going to affect the volume of blood we're pumping out of the heart. On the right side, remember always, on the right side, we're pumping to the lungs because we need to refresh our blood. On the left side, we're pumping to our body, to our neck, our head, to our limbs, trunk, etc. Then we're going to watch the video about the cardiac output, and we're going to remember some things about the nervous system on AP1. Watch this video, guys. Sharing with you, and now I'm going to show you this video.
1 minute. So here's a heart in systole, and the ventricles are contracting, ejecting blood out to the aorta and the pulmonary trunk. The cardiac output is defined by the amount of blood ejected by each ventricle in 1 minute. And there are 2 factors that are used to calculate the cardiac output. These are your heart rate and stroke volume. Your heart rate is essentially your conduction system of the heart. Your heart rate is how many beats per minute, so beats over minute. The other factor is your stroke volume. The other factor is your stroke volume, which is the volume of blood pumped by each ventricle with each beat. So this is mils per beat. So therefore, cardiac output is equal to stroke volume multiplied by heart rate. And stroke volume is mils per beat, and heart rate is beats per minute. So as an example, a normal stroke volume would be about 70 mils per beat, and heart rate about 75 beats per minute. Cross the beats out, and your cardiac output is 5,250 mils per minute. And this is about 5 liters per minute, which is about right because the amount of blood passing through the heart each minute is about 4 to 6 liters. So the heart rate and stroke volume is used to calculate cardiac output. But there's another 3 factors which influence stroke volume. And so in total, there are 4 determinants of cardiac output. Let's take a look at these. So the first determinant, which we already talked about, is heart rate, which is your conduction system. This is how many beats per minute. And there are things that can influence your heart rate, known as chronotropic factors. So you can have positive chronotropes, which increase your heart rate, and negative chronotropes, which decrease your heart rate. An example of positive chronotropes is your sympathetic stimulation. Your adrenaline, noradrenaline, epinephrine, norepinephrine, these guys will increase your heart rate. Some drugs can also increase your heart rate, such as atropine. Negative chronotropes decrease your heart rate. This is your parasympathetic activity. So this is your acetylcholine. Some drugs, such as adenosine, can also decrease your heart rate. The next 3 determinants of cardiac output are the things that influence your stroke volume. The first being preload. Your preload is essentially the amount of blood entering the ventricles during diastole. So it's also known as, I guess, your end diastolic volume. Again, the preload is the amount of blood, the volume entering the ventricles, and this is during diastole. Preload can be influenced by, therefore, venous return, the blood volume, and also atrial contraction. And the preload, again, occurs during diastole because this is when your ventricles are being filled with blood. The next determinant of cardiac output, the third one, is afterload, which essentially occurs during systole, when your ventricles are contracting, ejecting blood out of the aorta and into the pulmonary trunk. Your afterload is essentially the resistance the ventricles must overcome to circulate the blood. And so you can imagine things that can increase your afterload. These are things such as hypertension, atherosclerosis, and vasoconstriction, because these things will increase the resistance and therefore increase afterload. The fourth determinant of cardiac output is contractility. This is how hard the myocardium must contract for a given preload. And there are things that influence contractility. These are inotropic factors. There are positive inotropes, which increase contractility, and then there's negative chronotropes, which decrease contractility. So positive inotropes, again, is your sympathetic stimulation, noradrenaline or norepinephrine. Some drugs such as dobutamine can also increase contractility, making it a more powerful contraction. Negative inotropes are things like your parasympathetic stimulation, so your acetylcholine again, and some drugs can decrease contractility, such as your beta blockers and calcium channel blockers. So those are the four determinants of cardiac output: your heart rate, preload, afterload, and contractility.
Okay, guys, I'm gonna stop sharing with you my screen for a second. I need to retake every single part of this video. The cardiac output, again, is the volume ejected, the blood, the amount of blood ejected from each ventricle, but that is in 1 minute. Then you need to know that cardiac output, it's depending on two main factors. The stroke volume, which is the amount you expel out of the heart for every single heartbeat. Then you have an amount of blood in your heart. This amount is going to be expelled out of the heart. Every single heartbeat, that volume is the stroke volume. Imagine you have in every single ventricle 100 milliliters of blood, mLs. Then of these 100 mLs, you're expelling almost everything out of the heart. Then maybe 80 ml or maybe 70 ml of those 100 you have inside. Then out of 100, you are expelling 80 or 70. This is the volume called stroke volume. And because we're counting the amount of blood going out of the heart in 1 minute, you need to know the heart rate, because the heart rate is the amount of heartbeats in 1 minute. Then you're multiplying that stroke volume by the heart rate. This cardiac output depends on 4 factors. Actually, the heart rate, it's one of them. It's not the same thing if you have, for example, 70, which is a normal heart rate, or maybe you're doing exercises, maybe you're doing some sports, and maybe your heart rate is going to be increased. Then that is going to be called chronotropism. Chrono is time, tropism is the feature or property of any substance or tissue. In this case, it's going to be the heart. Then chronotropism is referred to the heart rate. It's not the same if you have 70, which is a normal rate, or you have 150, which is going to be tachycardia. It's an arrhythmia. It could be normal because of exercise. It could be because some drugs, for example, sympathetic drugs. If you remember AP1, if you remember the neurotransmitter, then we know AP1, sympathetic nervous system, has adrenaline, noradrenaline, epinephrine, norepinephrine as a neurotransmitters. These are neurotransmitters for stress. Then they're increasing your heart rate. If you're increasing your heart rate, you're increasing your cardiac output, the amount of blood ejected from the heart in 1 minute. On the contrary, if you have, for example, bradycardia, because maybe you have a heart attack or maybe you have a bleeding, then you're going to have the parasympathetic, the acetylcholine going down. Your heart is going to be going down. Actually, if you massage this carotid artery, you have some receptors here in order to decrease your blood pressure, your heart rate, because you're using acetylcholine for that purpose. The second factor, the third and the fourth, all of them are affecting the stroke volume. And we have three factors. The first one is called preload. Preload is the amount of volume at the end of the diastolic. Then it's the ending diastolic volume. The volume that you have of blood inside of the heart during the rest, during the relaxation of the heart. The third factor is going to be the afterload or the resistance. Imagine if you have a pump, which is the heart, and you have a pipe, and that pipe have a blockage. If your pipe has a blockage, it could be hypertension, it could be atherosclerosis, a piece of fat inside of the blood vessel, then you have a higher resistance against the flow. You're opposing to the flow of the blood. That is afterload. And the fourth factor is going to affect as well the stroke volume, which is the power of contraction. It's the contractility. It's not the same force, it's not the same power that you have as a young student of anatomy and physiology the second in comparison with maybe your grandfather or maybe in comparison with a kid. The contractility is going to be lower, the power is going to be lower in a kid or an old person. Then these features called inotropism. Again, we have the effect of the sympathetic nervous system. For example, adrenaline, noradrenaline is increasing the contractility. Acetylcholine instead is decreasing the contractility. But that is normal for our body, but it could be because of a drug. For example, in patients with heart failure, you're receiving dopamine or dobutamine to increase the contractility. On the contrary, if you have hypertension or you have any problem with your heart pumping very hard, then you need to decrease the contractility. And you're using some drugs such as beta blockers or calcium channel blockers. And these are drugs to decrease the inotropism and decrease the contractility. When you decrease the contractility, you're decreasing your cardiac output. Guys, I know that, again, these could be overwhelming. These sessions are really hard because the heart, it's kind of hard. You need to read your slides again. You can rewatch this video again. You're going to have this session recorded in your detailed announcements. And next week, we're going to be talking about blood pressure and some regulations, nervous regulations, endocrine regulations about the function of the heart. Guys, do you have any questions so far? Let me know if you have any questions so far. You have a chat on the side. You can write on the chat. Let me know if you have any questions so far. Brianna, Jasmine, Osvaldo. If you don't have more questions, guys, I'm going to stop here the transmission. Thank you, guys. Thank you. Thank you for letting me know. Then if you don't have more questions, guys, see you on next Tuesday. Again, we're going to have the last session for cardiovascular system on that day. See you then, guys. Bye-bye.